Lions also for 1 year. Lions Eye Hospital also for 1 year. So today we are going to go live on Phakic IOL, that is eye acrylic phakic IOL, where we are going to show step by step what are the precautions we take, what are the steps we do during the procedure, and moreover, it should be a discussion part where we want to give a practical tips for those people who have joined here. So let us start the surgery now. So first and foremost, we need to see this is the box which comes. This is a phakic IOL, non-toric phakic IOL. You can see here the leading haptic will have hole towards the left side. We will show that even on the microscope. If you see here, the leading haptic will have a hole towards the left side, and the trailing haptic will have a hole towards the right side. So, two things you need to one is before you shift the patient. No need of any local injection. You can do it under topical anesthesia. Make sure if there is a steep axis of 0.5 and all, then you can give your incision of 2.8 along the steep axis, even if you are doing non-toric phakic IOL. So now we are going to load the lens. There will be a drape here.
Hello, can you hear me? Can the audience hear me? Can the audience?
Yes, sir. Yes, sir.
Yes,
Audible.
you are audible. Sir. You are audible. Sir.
No, or all, everybody are on the mute? Audience or?
Yeah.
So, sir, this is on webinar platform. So, I request all the, those who have joined as an audience, they have two options as a chat box and question answer section. So, if you have any doubt, any question, any comment, you can use those sections.
Feel free to ask anytime.
Yeah,
So
yeah, but sir, they can hear you. Yeah, they can hear you.
Yeah, this is the injector, and this is the lens, which is in a solution filled in a glass bottle. So we are going to show the process of loading the lens.
Thank you very much, Dr. Raghu. I'll take it from here. He is my able colleague. I'm very proud to have him as my cornea specialist. He's trained from PGI Chandigarh. I have operated ICL in India, but he's operated ACL in 3 different countries. Both of us, we thought we'll share our practical experience with you. Last week, Dr. Chinnappa, I heard he gave beautiful theoretical lecture to you. I wanted to complete it by giving you practical advice on how to put the ICL. As he told, before opening any ICL, please know where the leading hole is. What is leading hole? Leading hole is as soon as you put the ICL, you need to know after the ICL opens on which hand the hole is, left hand or right hand. So that is important. First thing is over. Next thing is the ICL will come in a bottle like this. Zoom. Can you zoom or bring it in? Open it. Oh, zoom it. Bring it near. Before that, saline wash. Bring it near. Bring it further. Okay. This is plate haptics for cataract surgeon. Bring it near. I wanted to bring it near. Sure. Yeah. See, for cataract surgeon, whoever has loaded plate haptics, it is the same principle. Before loading, I just wash my cartridge and fill it with visco. Now keep it aside. Now take the lens. It comes in a, zoom it here. Can you zoom this? Zoom. More zoom. Yeah. Gently pull it out and press by opaque and see.
You need to see the orientation and the curvature of the lens.
To see the orientation, it should be, the curvature should be up. The curvature should be up. Can you see the curvature? The curvature should be always facing up. And the hole should be on your left side before you place the ICL. These two things you make sure, don't hold the ICL in the middle, hold it always in the periphery. And since I'm presbyopic, I always do my loading in my microscope, which is safer, which I'll go to my microscope now. Go to the microscope view.
Sir, if audience has any questions, would you like to answer that at the end of the surgery or in between I should ask?
Can you go to the microscope view?
Viscoelastic, what we prefer is normal HPMC.
I don't prefer high molecular weight sodium hyaluronate or chondroitin sulfate. It is not needed. I will give you the reasons later. Can you see this, how I'm loading? Make sure the edges of the ICL is inside the ridges. Can you see these two ridges? These are the two ridges on your side and opposite to your side. Make sure the edges of the lenses is below this ridge. That is very important first. Especially the edges of the lens should be below. Don't touch in the middle. Middle is the thinnest part of the phakic lens. Don't touch it. So once you have loaded it, just press it gently and close the. You can close and see again under the microscope. No part of the ICL is
stuck to
the ridges. That is very important step before you put in, and your hole is on towards the left. This is your left. This is towards your left. This is very important step before you load it. And
next step is just to
this is your
engage the
delivery system. Just as you put any IOL, you just engage it and just push it gently. Just push it gently
and see the
movement. If it is smooth, now it is smooth. I'm satisfied. I don't want to push it towards the edge. Now I keep it I keep it in the saline like this. Since it is an hydrophilic material, you cannot let it dry. If you let it dry, it will become brittle and it will cut. So that is one more. Usually I change the gloves since my gloves is smeared with this one, Visco. I usually change my gloves now because it has become slippery. Patient comes up. Now shift the patient. Now you can shift the patient. I'll tell you about the patient. Patient is a 26-year-old male with a power of -10 spherical with -2.5 cylinder, white to white of 12, ACD of 3.24. All the angles are open. CD is normal. Retina has been checked by me and the retina surgeon. All the angles are open. That is very important before you put the ICL. Get your white to white again check. About the white to white, you can check it in two ways. Either you can check it on your pentacam or OpsCam. To confirm that, you can either check it on your manual caliper. Sorry, on your digital calipers. What I do is I check it in my Hewitt's ARK machine, which can take the photograph and which has a digital calipers, which is very, very easy. For you to check it with the digital calipers, manual digital calipers, you have to get the patient to the OT, put in the drape, and it's a big headache. But with the Hewitt's ARK machine, you can take the picture and you can measure the white to white with the digital calipers. Or else, if you have the OpsCam in front of you, very good. You take 3 values of white to white and 3 values of ACD. That is very important. If you are there, I prefer to do it myself. I prefer to do few things on for the ICL myself. Start myself. First thing is refraction. Refraction is very important. First do the refraction, dilate the patient, see the retina, take the AR and do the PMT. I do the PMT on myself on a phoropter. If you have a phoropter, it is fine, or else it's okay. Doesn't matter. Refraction is very important. Checking your white to white is very important. White to white because your sizing of the ICL depends on that, and your ACD is important because it determines your voltage.
Few of the parameters which is required for any phakic IOL calculation would be the K1, K2, the corneal thickness, anterior chamber depth, white to white, axial length, and of course, both the type of refraction, that is manifest refraction and the dilated refraction. White to white, yes, OBSCAN is the best. Then digital caliper. Pentacam does give white to white, but compared to OBSCAN, Pentacam is not that accurate. If you have UBM facility, you can do sulcus to sulcus measurement of white to white.
Yes, that is the most accurate.
That is the most accurate.
One more thing I wanted to tell you is I always prefer to do my ICLs under topical and in the temporal incision. Why? Because obviously the axial length will be more. Any ICL I do will have an axial length of about 26. So if you block the patient, you end up with danger of penetrating the sclera. So doing topical, be confident, nothing will happen. Use intracameral 1% lignocaine, which is preservative free. Sit on the temporal side because all the ICLs or phakic eye lenses are designed to sit horizontally. If it is toric, slightly 10 degrees or maximum 50 degrees off. You cannot rotate to the vertical position. So if you put a superior incision, what happens is you need to rotate once it is in the AC to the temporal position. That what happens there is you might damage the angle structures, or you might damage the iris. If you touch the iris, it will again become small. So all those headaches will be there. So sit on the temporal side comfortably. Yenappa, aramagirappa, Govinda. Aramagiro. Very important to reassure the patient. You need to know your patient before. They keep reassuring your patient. And bottle light kami panma. Since it is high myope, sclera is very thin, it will stretch. Kai kelgade idappa, Govinda, please kai kelgade idappa. Kai mele tegi bada, please. Sak eshtiದೆ, ಎಷ್ಟು centimeters ಇದೆ ನೋಡು? 60 centimeters ಇದೆ, ನನಗೆ ಕಾಣಿಸೋದಿಲ್ಲ ಅದು. ಎಷ್ಟಿದೆ ಅಲ್ಲಿ?
See here, you can see the leading haptic hole, which is towards the left side, and this is a trailing haptic where it is towards the right side. So always make sure that your phakic IOL is oriented in such a way, and there will be a curvature when you place an ICL while loading. You can see the curvature, convex surface on the top. So it has to be loaded in such a way that the leading haptic will be towards the left side.
I have a coaxial. This is coaxial. The glow will be very nice. This is, see, he can't tolerate the light so much. That's why I do it in coaxial. This is very tolerable for him. This is very low illumination. All these small things matters. ಹಾಗೆ ಇರಪ್ಪ, ದಯವಿಟ್ಟು ಅಲ್ಲಾಡಿಸ್ಬೇಡ ಇವಾಗಿಂದ. ಹಾಗೆ ಇರ್ತೀಯಾ? ದಯವಿಟ್ಟು ಅಲ್ಲಾಡಿಸ್ಬೇಡ ಪ್ಲೀಸ್. This is 2.8 millimeters incision. ಹಂಗೆ ಇರಪ್ಪ. ಹಾಗೆ ಇರು, ದಯವಿಟ್ಟು ಹಾಗೆ ಇರು. ಹಾಗೆ ಇರಪ್ಪ. You're doing well. You're doing well. I do all the 3 ports together. Please don't do it. Since I'm experienced, I'm doing it. Do each port. After first do the main port, put the visco, and do the other ports later after putting the visco. Put your visco over the cornea so that it will be hydrated. It will not get dry. Don't overfill the AC. Fill it adequately. That should be enough. It should be soft. It should be soft, but not tight. Just press and see. Yeah, this should be enough. ಹಾಗೆ ಕನೆಕ್ಟ್ ಮಾಡ್ಕೊಂಡು ಲೆನ್ಸ್ ಇದೆಯಾ? ಲೆನ್ಸ್ ಕೊಡು, ನಂಗೆ ಆಸ್ಪಿರೇಷನ್ ಕೊಡು. You can do, to fixate the globe, you can do 2 things. You can either hold the globe in Hoskins forceps, or you can do this technique. Lens kodu. I hold, I stabilize. ಗದ್ದ ಮೇಲೆ ಮಾಡಪ್ಪ, ಗದ್ದ ಮೇಲೆ ಮಾಡು. ಹಾಗೆ ಇರು, ಅಲ್ಲಾಡಿಸ್ಬೇಡ, ಅಲ್ಲಾಡಿಸ್ಬೇಡಪ್ಪ. ಲೆನ್ಸ್ ಒಳಗಡೆ ಹೋಗ್ತಿದೆ, ಇವಾಗ ಅಲ್ಲಾಡಿಸ್ಬಾರ್ದು ದಯವಿಟ್ಟು. 2 ನಿಮಿಷ ಅಷ್ಟೇ. ಗೋವಿಂದ, ಆರಾಮಾಗಿರೋ. ಓಕೆ, I just stabilize my globe. Counter pressure can also be put, counter pressure and with pressure. Now the lens is going in. Lens, you put it very slowly. Now the lens is opening. Wait till the lens opens. Here at the half point, wait till the lens opens. This is the crucial part. If it opens on the other side, ulta, you can always withdraw now. Now I am putting it slowly.
You
I
can
put
see the leading haptic having the hole towards the left side.
I put the leading haptics directly inside the iris. This one. I have taught myself to do that, but there's no need for you to do that. You can also always tuck it in. Now I have to tuck in only the trailing haptics. In the principle here is you cannot touch the crystalline lens. Cortex.
Since there is a central hole, you don't have to do
PI.
PI.
For this. And biotech, what I have used hundreds of biotech's Phakic lenses. It is one of the best lenses what I've used. Yes. Now it is in. Now tucking is over. Now next step is very important. You have to take out the visco, whatever you have put, or else next day you will have very high pressure. You at least take 5 minutes to do this. Bottle height is 90, yeah. I do this for 5 minutes. Just keep first remove the visco which is behind the phakic lens. You just keep your irrigation at the hole. Can you see the hydro-like thing which is coming?
Drainage of the visco and the saline
The
is
visco, yeah, saline is going
central
through
hole.
the central hole, and it is coming, going behind the lens and taking out the visco, which is behind the lens, which is the first thing what I do. Or else, if you do this in the second attempt, the AC will collapse. I don't want that to happen. That's why I do this first. Chin up. Chin up. Center madapa. Chin up mada ಸ್ವಲ್ಪ. Chin up. Sir.
Make sure that you remove viscoelastic even from the angles.
Don't touch the endothelium. Don't touch the center part of the lens. Just place it in the center part of the lens and let the your IA do the rest. Do this for 5 minutes. Be patient. It will take some time. Don't worry about it. My parameters are 350 vacuum. Aspiration is around 30, I think. Visconal idiyalappa? Cortex idiyala? Yeah. Remove it thoroughly. You can do it in 2 ways. Either you can use bimanual IA, or else you can use coaxial IA, or else you can use, some people use Simco also. I'm comfortable with this since I am very used to the bimanual IA. I'm very used to the bimanual IA. I remove it thoroughly until I see all the strands of visco removed. I keep chin mel madapa. Yes. I've handled all sorts of lenses, from Star ICL to Biotech ICL, from APA to IOCare, everything. BioCare gives you predictable results. APA's for me also, IOCare also, but here they have ready stocks and they give you the lenses immediately if it is spherical, and about 2 to 3 days for your toric lenses. That is a disadvantage of Biotech, what I found. And the results are pretty predictable as well in biotech. That's why I prefer this lenses. ICL, it is a completely different ball game. The loading is different, loading system is different. Yeah, we are done, I think. Now only thing which is left is to close the AC. See the light nodapa. Aram gidiyappa, Govinda? ಆಗೋಯ್ತಪ್ಪ, ಚೆನ್ನಾಗಾಯ್ತು. ಹೊರಗಡೆ ಕೂತ್ಕೋ, ಹೊರಗಡೆ ರೆಸ್ಟ್ ತಗೋ, ಬಂದು ಮಾತಾಡ್ತೀನಿ ನಾನು. ಓಕೆ, ಏನು ನೋವಾಗಿಲ್ಲ ನಾನು ಮಾಡಿರೋದು. ವೆರಿ ಗುಡ್ ಸರ್, ವೆರಿ ಗುಡ್. Just wash finally whatever is there in the AC. Now we are done. Post-op care, I think you know, but I myself and Dr. Raghu both will repeat. For your benefit, I keep my patient 1 or 2 hours after the surgery. I check the IOP. If the IOP is high, I give a couple of Dimox after the surgery and send. Right, Kansidiyapa?
Oh, yes, sir.
Let's bradapa. Agoytu. Surgery aaytu. Right, Kansidiya? No ಆಗ್ತಿದ್ಯಾ?
One intracameral pilocarpine,
ಆಗೋಯ್ತು.
we don't prefer. Since there is a central hole, you don't have to really use intracameral pilocarpine.
ಆಗೋಯ್ತು, ಚೆನ್ನಾಗಾಯ್ತು. ಒಳ್ಳೆ ರೆಸ್ಟ್ ತಗೋ, ಬಂದು ಮಾತಾಡ್ತೀನಿ. Yeah, you can close. No problem. You can close.
The most preferred viscoelastic is HPMC. Why? Because it is easy to wash, and chances of post-operative IOP spike is very less compared to sodium hyaluronate or any other high viscosity viscoelastic OVDs.
Now we'll have a sort of panel discussion before I go to my multifocal. Any doubts you have regarding you know?
You ever had remove ICL?
Yes, I have had to remove the ICL because it has gone couple of times the other way. Taking out the ICL is very simple. It is not very complicated. You put a lot of visco behind the ICL and above the ICL. Don't overfill it again. Hold one of the haptic, which is trailing, and pull it out gently. You can use 2 McPhersons. I call it rope and pulley technique. You can pull it out very easily. It comes out very easily. It's very malleable lens. It comes out very easily. I've had a couple of occasions where it had gone the other way around, which I had to remove. Yes, in my initial days. That is in 2011 or 12. I don't remember properly. Yes, that's why I told you 10 times you need to see the orientation of the lens. Each company has the hole on each side. Even now, even though I put thousands of ICL, even now I see the hole of the ICL and then put.
The hole in
And what about patient like patient?
Manali, is it you? Tell
Yeah.
me.
No, like any patient has complained like post-op any refractive related complaints.
Yes, see, good question.
Like any glare, halos.
Yes, since there is a central hole for first 1 or 2 weeks, people who patients, you need to see the, apart from white to white ACD, you need to see the pupil diameter also. Please don't put ICL if the pupil diameter is about 5, because they end up with glare, and especially in night driving, they end up with glare. So be careful about your mesopic pupil size. Okay, and central hole, some certain people, type A personality people, may complain of a small glare, especially during driving, wherever he sees a headlight or things like that. But it will settle down. Reassure the patient. 3 weeks or 1 week, or sorry, 1 month or 2 months, it will settle down. Any other thing you want me to ask?
And these like, is the complaint bad enough to remove it, or we can
No, I have
tell them
never
that
removed.
it will settle?
No, I have never
It
removed
will
it.
settle down.
No,
Okay.
it will settle down. I have never removed an ICL. I don't think you have also removed, Dr. Raghu.
no.
I have never removed an ICL till now because of the glare. I have removed the ICL for 2 reasons. First, both the reasons being, I have placed the ICL on the, when it came out, it went the other way around. Both the occasions
So-
was that.
That was handled
So when you
on the
maneuver
same-
it,
On the same,
on the same,
and
during the procedure itself.
advantage of biotech is they give you 2 lenses. If one lens breaks also when you're taking out, there is always a backup lens. You can put that also. That is the advantage of biotech. Okay.
so when you're taking it
asking
out,
for, tell me.
No, when you're taking it out, then you can turn it, flip it, and put that same lens
No,
back,
no,
or
no,
do you
never.
think you should
No,
put
no,
a?
no,
Ah.
no, never flip
Ah.
the ICL in the AC. There is no enough space. I told you the main principle of ICL is never touch the crystalline lens. If you touch the crystalline lens, it will become cataractus. It is like a touch me not plant leaves. As soon as you touch it, it will become cataractus.
So her
So
question
if you,
is, can we re-implant the same?
same thing you can,
implant.
same thing you can replant. If the lens is not damaged, I re-implant the same lens. But I have seen few people who flip the lens inside the AC. Please don't do that. You should. That is never indicated.
That causes endothelial damage for sure.
Forget about endothelial damage. It causes cataract. So many other problems. No, never do that.
And what if you hit the lens capsule? Like what? Like even if you just, I'm not saying like fully damage it, like a small hit. How do you know it then and there? And because only after some time post-op, maybe you can see the cataract and all. At that time, you may not be able to make out, right?
No, immediately cataract will not come. It'll take about a week or two. It will start with anterior subcapsular cataract. Okay.
Yeah.
And then
so
it will
how
go
can
on
you?
to. I have had
Okay.
one cataract till now, wherein I had to explant the ICL and do the cataract surgery. Till now, only one like that, where the sizing of the ICL was wrong in that. Make sure that's why the vaulting is more than half the corneal thickness. So it is about if you presume an average corneal thickness of 500, it should be about 250 microns.
On an average, the vaulting, what you should expect is somewhere between 250 to 700 microns.
Anything beyond or below that,
beyond,
you need to exchange.
You need to be very careful.
You need to exchange. No second thoughts. Please exchange. Before exchanging, reassess the white to white, and then talk with your R&D group with the biotech, and then go for exchange. Because when you're going for exchange, already patient will be traumatized mentally. I don't want you to, or I don't want us to go wrong the second time as well. So be prepared nicely for the second time, both theoretically and practically. Any other thing?
There is one question by Dr. Gargi Nagpal. So Dr. Gargi, you can ask the question. You are having the audio, right, Dr. Gargi?
Sorry.
Okay. Hello,
Yes.
sir. Sir, this
Yes,
is Dr. Gargi from Bulandshahr.
Yes.
Uttar
Please tell me. Tell me.
Yeah, please tell
We
me.
can hear you. Go on.
Sir, can you hear me?
Yes. Tell.
You told that the patient had pre-op astigmatism of 2 diopters.
No, not 2.25. This patient, what I,
Oh, okay. So it was my hearing mistake.
anything above -1, I prefer toric.
Sorry.
Anything
Okay.
about -1. Up to -1, I can do OCCI and manage with incision. OCCI is opposite clear corneal incision. I can
Yes.
2.8 and 2.8 incision on the opposite side. I can manage up to -1. Beyond -1, I can't manage. So I
Along
go
the
with
steep
the
axis.
toric lens. Toric lens is the best choice. This patient
Okay.
had 0.25.
Okay, sir. So one more question I would like to ask. Sir, is it necessary to have a setup of OBSCAN, Pentacam before planning for ICL?
No need to have. Don't invest on all those things. If you have it,
Yes.
it's fine. If you don't have it, no problem. You can always send the patient to a center,
Refractive center.
to a reliable refractive center where they send the patient back. Make sure of that.
Yes.
They'll do the OBSCAN or Pentascan to you. Okay. You need an OBSCAN for your corneal thickness, for an ACD. ACD, particularly for the ACD, we can't calculate. Rest everything we can calculate with the whatever machines we have. But ACD from the endothelium we cannot calculate. For that we need corneal thickness and the ACD, which minus itself, which happens only in Pentacam or OBSCAN. So you better Cirrus. Okay.
Okay. Thank you, sir.
Thank you. Because your Pentascan is around say 28 lakhs, I think. So it is not worth. If you have a very good practice, cornea practice, it's worth investing. Or else, I don't think just for ICL, I don't think it is worth investing for Pentascan or OBSCAN.
That's what I wanted to ask, sir, because we are having basic this.
Okay.
That is sufficient for you.
I have
to
started doing my ICLs from my basic setup. We can do it. You can do it.
Yes.
It's a very simple. Doing ICL itself, as you saw, is a very, very simple. It took me hardly 1 minute to put the ICL and 2 minutes to putting the ICL is just a technician's job. I hope my teacher VP madam is there. She always used to tell me it's always a technical thing. You can learn it. The learning curve is very small. Be confident. You can put the ICL very easily. Just remember the principle. Don't damage the iris. Don't damage the angle structures, and don't touch the lens while putting. These are the very basic principles. If you remember, that is enough. It is the learning curve is very short compared to Phaco or your LASIK. It's very easy, ma.
Number one, one more thing is, you see star ICL versus this eye acrylic phakic lenses. There are few advantages. Number one, they give two lenses. Number two is they deliver very fast. Number three, you don't need any special forceps or an instrument, whereas in star ICL you need to purchase it. For that itself they charge somewhere around 30 to 40,000. Here you don't need any extra instruments. Just your phaco set is sufficient for you to load the lens and do the surgery.
Any other thing?
So I
Shall
think
we
sir,
go?
we
Okay.
have one more question. It is related
Yes,
to rotation stability in long term, sir. What about the phakic toric rotation stability in long term?
It's very good. Phakic toric, provided if your sizing is good, it is good. If you've calculated a small, if your ICL is smaller than what your calculation is, then it rotates. Okay, or else the rotation stability is quite good. Usually it doesn't rotate as, see, like our IOLs, it doesn't rotate as easily as IOL because it's a big lens and the space for it is too less for it to rotate. That's why you can't rotate more than 15 degrees. Once you put the ICL, you can't rotate more than 15. It's very difficult. Without damaging the ciliary body, it is very difficult to rotate once you put in.
And also the one more advantage is Indian phakic lenses, the range of refractive power what you get is much more than the star ICL.
You can customize it.
Customize it, yeah.
You can customize your this one. 19 is the final thing you get in ICL, star ICL. You go up to 21.
If you don't want to rotate any toric phakic lenses, you can ask the company to give a customized lens where the toricity is well maintained and you can place the lens horizontally only.
180 degrees if you put it, they'll do the toricity in the
But
customized
that takes
manner.
time. That
It takes
time.
15 days time minimum.
So thank you very much for pointing out that thing. Yeah, we have the acrylic phakic lenses with available for +10 to -25 diopter. So
Minus 20,
as you-
yeah, fantastic. Yeah.
as you rightly said, so we have the range, and if in phakic toric also we have a range between +8 to -25. So that is
Ready,
the-
na? Dialect ಆಗಿದ್ಯಾ?
So a few advantages are
Drop,
there with Indian phakic IOLs. The only
lens
thing
ಅಲ್ಲ.
we should keep in mind is
Direct
whereas star ICL they tell like 2.7 or 2.8 is what is the AC depth where you can do minimum AC depth which should be there for your star ICL. Here the lenses are little thicker, so I prefer to do when the AC depth is more than 2.9 or 3. Then I can easily put any Indian phakic
Yes,
IOLs.
I agree with him. See, star ICL is slightly thinner than our all Indian phakic lenses. Star ICL, I keep the cutoff at 2.8, but here in Indian ICLs, I keep the cutoff at 2.9 or 3. 3 is you're very safe. Okay, and check for the angles. Keep the 4 mirror. Check for check for the angles. It should be open in all the 4 quadrants. Please check for that.
What is the lowest power?
Which is the
Lowest.
lowest power? Lowest power what I've implanted is 3.75, I think. His cornea thickness was 450 or something. He was not at all fit for PRK, and he wanted to get rid of glasses at any cost. I think it was 3.75 in 2015. I think I have implanted. It's one of the sisters. It's a she. It's one of the sisters who was working in Saudi. I remember her. Yes, that is the slowest I've implanted. Anything else? Shall we go for the next case?
we
Prepare, madam.
don't see any further questions. So
Anything
thank
is
you
there?
very much.
Dr. Raghu will be answering the ICL. I'll go for the next case, which is multifocal. Okay.
And to avoid any kind of background disturbances, I'm again putting the rest other surgeons in the attendees list. And once you have any doubt, any question, you can put in the chat box question, or you can raise your hand. So at the end of the surgery, I will put you in the panelist, and then we can have a discussion. Yes, sir.
ICL ತಗೊಳ್ಳಿ ನಾನು ಸರ್ಜರಿ ಮಾಡ್ತಾ ಇರ್ತೀನಿ. ಚೇಂಜ್ ಮಾಡ್ಬೇಕಲ್ಲ.
So now we are going live for multifocal. That is also from biotech. With the lens box. So they have trio also, that is trifocal. We have put a lot of lenses trifocal, more than 150 we have put in this OT. So the results are very good with trifocal, that is trios. This is an Indian version of multifocal. It is little yellow colored, not like panoptics color. It is very lightly tinted yellow color. The results what we get is very good here. Now we are going to show the process of multifocal insertion. Box sound bar. Just ಇದನ್ನು
ತೋರಿಸ್ಬಿಟ್ಟು ಆಗಲ್ಲ ಅಲ್ಲೇ ಇಟ್ಬಿಡಿ.
So this is the lens Activa, which is having a near red of +3. It is wafer design, 360-degree advanced square edge, and a natural chromophore. It is not that yellow when you compare with IQ lens or your panoptics. It is slightly tinted yellow color chromophore.
This is a 65-year-old lady, hypermetropic. She wanted to get rid of glasses. See, for a surgeon, two challenges will be there. One is dealing with very hard cataract or dealing with very soft cataract. Hard cataracts, lot of my surgical videos are there in YouTube. Here it's a very soft cataract. I'll be telling you various techniques what we can use to take out a soft cataract. Both are challenging. Both extremes are challenging. Softest and hardest. Grade 5 and grade 1. Both are challenging for the phacosurgeon, especially with a small rhexis, which has to be a criteria for a multifocal or toric IOL. I always prefer hydrophobic multifocal or triphobic, whatever I'm putting. I prefer hydrophobic because it immediately goes and sits, attaches itself with to the posterior capsule. It doesn't move. The hydrophilic, especially with the plate haptics or double haptics or modified C haptics, it doesn't matter. It keeps moving. So the ELP keeps moving. ELP is effective lens position, which without if it keeps moving anterior and posterior, I can't predict the post-op refraction. One is that, and I would have centered the ring according to the centration of the pupil. That centration also goes sometimes as the capsule contracts in hydrophilic, which I don't like. So I usually prefer hydrophobic, whichever company it is. This company is good. I'll be demonstrating now. Coming to the settings, and the settings, settings, can you see? These are my settings. I don't change my settings. It is same for everything. Everything is in linear mode. Either grade 1 or grade 5 or grade 6, it doesn't matter. The settings will be the same. Only thing which is going to change is IP on or IP off. Only that is saying that will change. Grade 3 and above, IP will be on. Grade 3 and below, IP will be off. That is the only difference. Here I think IP is off. No. Here IP will be off since it is a soft cataract. IP will be off. Bot light will be around 120. I try to manage the vacuum and power what is needed through my foot pedal control. ஆறாம இருங்கம்மா, பயப்படாதீங்க. சரியா? ஒன்றும் ஆகாது. ஒரு லைட் வரும், அதே பார்த்துட்டு இருங்க. சரிங்களா? லைட்டை பாருங்க. அப்படியே இருங்க. ஆறாம இருக்கீங்களா? கம்ஃபர்டபுளா இருக்கீங்களா? வெரி குட். ஒன்றும் வலிக்காது. ஒன்றும் வலிக்காம பண்ணி தரேன் நான். சரிங்களா?
Three things
Relax.
you should keep in your mind when you are doing multifocal is one is getting the proper axis, which should be well centered.
2.2. 2.2. करके ना कीजिएपा.
And after insertion of the multifocal, centration of the multifocal using the Purkinje reflex light, you need to center the lens along the visual axis.
நேரா பாருங்கம்மா, லைட்டா பாருங்க, அப்படியே இருங்க, ஆட்டாதீங்க, தயவு செஞ்சு ஆட்டாதீங்க, ஒன்றும் வலி ஆகாது உங்களுக்கு. சரிங்களா? ரிலாக்ஸ். இப்போ கொஞ்சம் சுருணும். That's all. From now on, you will not feel anything. Okay? Relax, ma. See, as you can see, the red glow. It's a very soft cataract.
Right.
Relax, ma. Relax.
Show me how it is. ಚೆನ್ನಾಗಿ ಇರ್ತೀರಾ?
ಏನು ಕೊಯ್ತಾ?
ಇಲ್ಲ, ಇದು ಸರಿಯಾಗಿ ಕಾಣಿಸ್ತಿಲ್ಲ. ಒಂದು ನಿಮಿಷ
ಫೈನ್ ಟ್ಯೂನ್ ಮಾಡಿ.
ಒಂದೇ ಒಂದು ನಿಮಿಷ. ಒಂದೇ ಒಂದು ನಿಮಿಷ.
ಸೆಂಟರ್ ಮಾಡಿ. ಸೆಂಟರ್ ಮಾಡಿ.
Okay.
Okay.
Okay. Yeah. Now it is coming. Yeah.
Well, I'm going ahead. So it was some problem with the focus. I hope everybody is seeing clearly. Small rexes around 5 millimeters. Aim for 5 millimeters, not more than 5.5 millimeters maximum. As you can see, it is perfectly round, 5 millimeters rexes. This is the key in multifocal. Decompress the AC. Follow your basic rule. This is hydro dissection. See the wave. Decompress. Come out. Put the visco. Rotate. I use a 1.5 millimeter needle chopper. Continuous irrigation. So, you know, it's okay. See, first chop is okay. I got it. Second chop, okay. And the third chop. Yes, we're done with the chops. I change it to the dialer and make sure it is separated. Saline idella. Now we can eat it. Centration idea?
Yeah.
Centered?
Yeah, yeah.
Visible? Clear?
Yeah, yeah. ಸ್ವಲ್ಪ ಈ ಕಡೆ ಮಾಡಿ.
Chin down, center ಮಾಡು.
Yeah, perfect.
We're done with the phaco. Next is cortex removal. If you are well versed with your phaco pedal, I can do even trenching in this 550 vacuum. It's okay. I've trained myself to calibrate my, control the vacuum power, whatever I need through foot pedal control. Load ಮಾಡಪ್ಪ, lens load ಮಾಡು, D cartridge ತಗೋ. Usually my assistant, Muniraj, has been assisting me from past, say, 8 years now. He is very good in assisting. So half my headache is over there. Bit of epinuclear plate is left. That's why I'm struggling a little bit. It's okay. Take your time. Polish. Don't forget to polish the capsule because it's a small 5 millimeters excess, or else it will undergo phimosis. Remove all the epithelial cells as far as possible to the equator, so that both PCO and phimosis you can prevent as far as possible. Light parangama. Dayasenja light paranga. Light pathittrunga. Bayapadadinga. Mududhu. ಯಾವ್ದ್ರಲ್ಲಿದೆ? ಪಾಲಿಶ್ ಇದೆಯಾ? Polish nicely again to the equator. I don't like to leave even a single fiber. Now I do hydroimplantation. Advantages of hydroimplantation is, I'll tell you. Put this last step now. Relax. Yeah. Advantages of hydroimplantation is, first thing is it gets more quicker. More than that, the lens doesn't move because there is no visco behind the lens. So the chances of IOP raise next day due to IOP retention and chances of your TARS because of your retained visco is also less. To position the lens roughly now, I'm going to fine tune it later. Now I'm going to close. While I'm closing, I'm going to fine tune the centration. Now I'm the centration. Now I'm in the coaxial mode. So it is around 66 degrees projection. Coaxial mode is around 6 degrees projection. Oblique mode is around 45 degrees. Remember that. The Purkinje fibers position depends on that. So remember your theory. There are 5 Purkinje images total here. Yeah, place it now and light a paragama. Light a center paranga. Ah, very good. Now see, it is perfectly centered. Now I will close it finally. That's it. The surgery is over. Alla achima surgery ಚೆನ್ನಾಗಾಯ್ತು. ಹೊರಗಡೆ ರೆಸ್ಟ್ ತಗೊಳ್ಳಿ, ಬಂದ್ ಮಾತಾಡ್ತೀನಿ. ತೊಂದರೆ ಆಯ್ತಾ ನಾನು ಮಾಡಿದ್ದು? ಇಲ್ಲ ಇಲ್ಲ. ವೆರಿ ಗುಡ್. ಚೆನ್ನಾಗಾಯ್ತು. ಓಕೆ, ಹೊರಗಡೆ ರೆಸ್ಟ್ ತಗೊಳ್ಳಿ, ಬಂದ್ ಮಾತಾಡ್ತೀನಿ. ಡ್ರಾಪ್ಸ್. சாரி, அப்படியே இருக்குமா? கண்ணை தொடாதீங்க, கண்ணை தொடக்கூடாது. Any questions on multifocals or thing I'm happy to ask, I'm happy to answer. Basically, I'll tell you how to choose a multifocal. Usually multifocal I choose in patients who don't drive in the night, especially. Occasional driving in the night is okay. And astigmatism should be less than -1, or else I go for toric multifocal. Below -1 is ideal for your normal triphobe or multifocal. She had an astigmatism, corneal astigmatism. Astigmatism in the sense, not what you get on your AR. What you get on your AR is the combination of cornea, lens, and retina. No, not that. You have to take your K1, K2, and the difference between that should not be more than -1. That is what I meant by astigmatism. Okay, that should be not more than -1. If it is, this is 0.25. If it would have been 0.5 and above, I would have done a OCCI again on the steeper plane. That is how I manage multifocals. No patch. Patient will not wear the patch. She'll directly, they'll put the drops. Any questions? I'm happy to answer.
Doctor, do you, since we have the bigger central clear area, do you consider the angle alpha calculation for critical for the active cases?
Huh? What did you ask?
Angle alpha.
In a patient with hyperopia, yes, you need to decenter the lens by 0.5 mm, considering the angle kappa. If it is
Angle kappa you're asking. Correct. Good question. Yes, your angle kappa. See, what is angle kappa? The difference between the visual axis and your pupillary axis. If it is more than 5 degrees, please don't put any. Please go for monofocal. Don't put anything else. Okay, monofocal. Any monofocal will do. Please go for monofocal. If your difference is more than pupil center and the visual axis, if it is more than 5 degrees, please don't put multifocal. They'll never be happy.
If it is less than 5 degrees, you can just slightly decenter based on your Purkinje images.
Yes.
Thank you.
Any other questions? Any other questions you have? I'll be happy to answer. Or else we can wrap it up and thank the biotech team for arranging a beautiful meet.
Thank you all for joining.
Yeah. Any other questions are there? I'll wait for 2 minutes. The last questions here. If you have any questions,
They are answered, sir. We have asked this question.
Thanks to Raj for arranging in such a short notice.
thanks for our OT staff. This is Muniraj. This is Raj and Kalai. Kalai is on offside. Thank you, everybody. Thank you for the team.
Thank you, Dr. Naveen Gopal. Thank you, Dr. Raghu, for such wonderful explanation and wonderful demonstration.
Thank you.
Thank you very much for coming.
Thank you from biotech, sir.
Stop.
Yeah, right.
Clean my button.